Good evening. I am Dr. Bijay Patni from Calcutta, India. At the outset, I would like to thank Professor Nozi Yusuf for inviting me for this global summit of Egyptian Cardiodiabetic Association and giving a very interesting talk on caramel disease. Caramel disease, what I am going to talk is of a concept which has not yet come in the medical literature. The concept has some uh, interesting facts to discuss. So, caramel disease is a multifaceted approach to metabolic health. Though it is not officially recognized medical literature, but it represents a conceptual framework for understanding the complex interplay of chronic conditions often associated with metabolic disorders like type 2 diabetes. These conditions often co-occur, create a cascade of health challenges that require a comprehensive and multidisciplinary approach to manage effectively. Now, let's look into the concept. The idea of caramel disease leverages the concept of caramel as something that is a blend of various ingredients. Here we are considering chronic conditions that come together to form a unity or unified entity. Just as caramel is created by the fusion of sugar and heat, disease represents a conglomeration of different health conditions: cardiovascular, renal, metabolic, eye, and liver disease that often coexist and interact in patients with metabolic disorders. Now, this metaphor is particularly apt because, like the smooth blending of ingredients in caramel, these chronic conditions do not exist in isolation, but are often intertwined, influencing each other's progression and complicate the overall disease management. So, it's extremely important that it is treated as a whole and requires a comprehensive management if we really want to settle the issue. Over half a billion people with diabetes are there, and which is almost like 1 in 11 or 1 in 10 adult population. Diabetes, enormous humanistic, societal, and economic burden is largely driven by the coexistence and severity of the cardiac, renal, adipometabolic, eye, and liver disease, collectively known as caramel disease. Now, type 2 diabetes mellitus and its comorbidity are primarily caused by a failure to effectively sequester the excess energy, leading to the accumulation of sick fat, adiposopathy. And this is the baseline problem. Rather, this is the driver which actually leads to the pathogenesis where almost all the chronic diseases get assembled. Type 2 diabetes is a symptom of chronic disease complex, just as cardiovascular, renal, eye, foot, and or liver disease are. In addition, each of these conditions feed forward so that the dysfunction in one of the system accelerates the dysfunction in another because they share a common pathogenesis, they have a common soil hypothesis, and also partly due to dysfunction that follows in their way. So, looking into the interconnection in the cycle of the disease, we are discussing the caramel disease, the metabolic dysfunction. Now, underlining the metabolic dysregulation lies the insulin resistance, chronic inflammation, and dyslipidemia, which ultimately set the stage of development of the caramel disease. Presence of caramel, one component of caramel, will exacerbate the risk of developing the other components. Thereby, a vicious cycle of disease progression and escalating health challenges occur. All this will lead to the impacting the quality of life, and which will ultimately lead to physical limitations, emotional distress, and increased healthcare utilization. So, considering this conglomeration of the various chronic conditions, a comprehensive and multidisciplinary approach is essential to manage this caramel disease, addressing all involved organ system and addressing the underlying metabolic dysfunctions. So until this you address all of them together and have a holistic approach, probably you won't be able to address this mix or this spectrum of chronic conditions and get the desirable outcome. Let's look into the various component of this caramel disease. The one such component obviously is cardiovascular disease in type 2 diabetes. Now, all of us are aware that In patients with type 2 diabetes, at least one in three patients will have atherosclerotic CVD. And individuals with type 2 diabetes are more prone to heart failure. So there is a reduced quality of life, there is admissions, readmissions, and reduced survival. Atrial fibrillation also increases the risk of heart failure, and it is more common in type 2 diabetes patients, especially due to cardiac stiffening. The presence and severity of atherosclerotic CVD and or heart failure are the strongest risk factor for reduced survival in type 2 diabetic patients. Sudden cardiac death is not very uncommon in type 2 diabetic patient, and is almost twice as common in these group of patients vis-a-vis non-diabetic population. So why do cardiovascular disease occur? Because there is an increased risk factors, heightened risk factors in patients who have similar kind of chronic conditions. So individuals with metabolic disorders face a heightened risk of developing cardiovascular disease, and the underlying metabolic dysfunction often is characterized by insulin resistance and chronic inflammation. All together leads to a fertile ground for CVD development. And if you look at the various other components of caramel disease, like hypertension, dyslipidemia, obesity, almost all of them exacerbate the progression of CVD. The factor contribute to plaque formation in the arteries, leading to the narrowed blood vessels and impaired blood flow. So it's extremely important that early intervention and early recognition, along with management of these CVD risk factors, is essential and to prevent and also delay the onset of cardiovascular events. All obviously, lifestyle modification is the prime mover if you want to have a positive outcome in this, in order to prevent the cardiovascular disease. Next, we go to the other component, that is peripheral artery disease. Foot disease, we all are aware of the fact that is the leading cause of disability, hospitalization, amputation, and premature mortality, particularly in type 2 diabetic patient. And at least one in five adults with type 2 diabetes will develop a foot ulcer during their lifetime. One in five of these cases, the foot ulcer will fail to heal and will ultimately require intensive treatment, which could lead to increased hospitalization and could have amputation as the outcome. So PAD is found in approximately one in four people with type 2 diabetes, two to four-fold higher than the non-diabetic individuals. So it is the most common first presentation of atherosclerotic CVD in people with type 2 diabetes. The third component is chronic kidney disease. Looking into this, it is basically defined as the presence or persistent of an estimated EGFR rate of less than 60 or an elevated urinary albumin creatinine ratio. One in four men and one in three women over the age of 65 has an EGFR of less than 16. Now, if you look at the recent guidance by EgCDA, they really recommended that they avoid the use of the term chronic kidney disease or diabetic kidney disease. Rather, because of the fact that it is actually a complex renal pathophysiology that coexists and cooperates in most patients with type 2 diabetes and CKD. So it is the complex renal pathophysiology which exists. So it just you cannot define it as a diabetic kidney disease because it is also diabetic patients is having CKD. SGLT inhibitors are renoprotective agents. Exploration of novel agents targeting fibrosis and inflammation is now available. So these are the molecules which probably will give some kind of positive outcome as far as the chronic kidney disease is concerned. Next, we pass on to the metabolic associated eye disease in type 2 diabetes. Cataract are the most common cause of blindness, about twice more common in type 2 diabetes. 22% of the adults with type 2 diabetes also have some form of retinal disease or diabetic retinopathy. Eye disease is generally considered to be the manifestation of cumulative glucose exposure, correlating with the duration of type 2 diabetes and the glucose control over the time. So it's extremely important that you have to address the glucose excursion and to keep the dysglycemia well under control. Next, we pass on to the metabolic associated fatty liver disease in type 2 diabetes. What we are aware of the fact that hepatic steatosis of the fatty liver, where more than 5% of the cells of the liver are involved, they can be detected by early in the disease by various modalities like abdominal imaging, histology or biomarkers in presence of type 2 diabetes. And there, the disease per se is known as metabolic dysfunction associated fatty liver disease. And it affects about one half of all the people with type 2 diabetes, and possibly about 90% are also known, may go up to 90%, and they are also known as non-alcoholic fatty liver disease. But obviously, this term has been discarded now, and probably the best term to describe is metabolic dysfunction associated fatty liver disease. Alongside the steatosis, which we see approximately 1 in 5 individuals with MAFLD will also have histological hepatic fibrosis, which is regarded as the main prognostic factor of cirrhosis or hepatocellular carcinoma. So this again becomes a very special entity in the caramel disease. Let's look at the adipometabolic disorder, where the role of fat and the metabolism together are taken into consideration. We are all aware of the fact that the excess visceral fat releases the inflammatory substances that interfere with the insulin signaling, leading to the impaired glucose uptake and utilization. This, along with dyslipidemia, which is again an important component where increase in a free fatty acid occurs, and there is a fat accumulation in the organs, particularly in the liver, which can again lead to metabolic dysregulation. This lipid abnormality can contribute to the development of atherosclerotic and CVD. Adipometabolic disorders exacerbate the progression of other caramel components, including the CVD, renal disease, and liver disease. So it's extremely important that you manage obesity and dyslipidemia and thereby help to mitigate these risks. So again, the whole concentration, if you see in management of type 2 diabetes, is not only managing glucose, but overall managing or the holistic approach towards the management of type 2 diabetes, particularly the obese part, that is increased weight uh, uh, loss is expected of the management tool which we employ for managing type 2 diabetes, along with avoidance of hypoglycemia, and also add on to those factors all the other risk factors, including managing the dyslipidemia. So this is the conglomeration of the various chronic condition, which can ultimately lead to caramel disease. One side we have the cardiovascular spectrum, which can manifest as atherosclerotic CVD, heart failure, and cardiac death. Other factor, obviously, what we talked about, the liver dysfunction, that is MAFLD, and then the renal. You have the peripheral arterial disease, the eye component is also there, and ultimately the manifestation of type 2 diabetes as a part and parcel of the conglomeration of these chronic disorders. So this sticky clustering of the disease is what is known as caramel disease. So if you take the cardiac CA of the cardiac, and then you have the adipometabolic, and then you have the renal component, liver disease, the eye, and these all ultimately lead to dysglycemia, which will have insulin resistance as one of the most important factor, hypertension, atherosclerotic dyslipidemia, metabolic signaling defect, oxidative stress, microbiome alteration, inflammation, neurohormonal activation, all ultimately leading to end organ dysfunction. So you have multiple organs with targeted leading to the end organ dysfunctions, and that is what is increasing the risk of mortality and morbidity in individual. Now, if you look at the key regulatory proteins like AMPK, sirtuins, and mTOR, they all adjust to the excess nutrient which a patient receives. So the bonanza state of the nutrient surfeit sensed by these regulatory proteins act, uh, leads to the activity of these key regulatory proteins and thereby managing this surplus. But what happens? The adjustment doesn't work always in a cohesive manner, leading to the malfunction and ultimately affecting the health and functions of the cells. Who was the person who actually coined the word or adiposopathy? It was Harold Bays who coined the word adiposopathy and concluded that it is this sick fat which is the driver or the central driver of the caramel disease, and thereafter the metabolic syndrome appears. So the ultimate driver of the caramel disease is the sick fat, that is adiposopathy, and which probably is responsible for all the other factors which we see, or all the other condition which we see as a component of caramel disease. Then these will lead to the tissue specific manifestation, and ultimately will lead to the various organs being affected, be it cardiovascular, renal, eye, foot, and liver disease. Type 2 diabetes are also manifested in the same caramel disease. And this sticky mess driven by calorie excess, inactivity, and adiposity is the mechanism behind the caramel disease. Why do the concept hold? Now we have certain factors which can clearly define the fact that the concept of caramel disease, or the conglomeration of the chronic conditions which are basically intertwined together, ultimately leading to this particular disease, what we call as caramel disease. Because if you have a healthy fat, then probably you have all the protection, because they are able to sequester and expand. And in doing so, they suppress the formation of the sick fat. There are many obese individuals who do not develop type 2 diabetes and caramel disease. That means the healthy fat supersedes the sick fat. And that is why they are known as metabolically healthy obese individuals. And people with lipodystrophy, adipocyte dysfunction frequently results in premature type 2 diabetes, atherosclerotic CVD, hepatosteatosis, and CKD, but not because of type 2 diabetes or obesity. So it's not always when you see a patient is type 2 diabetic or obese, but still might be having a manifestation of atherosclerotic CVD or liver disease or CKD. So that is why what we probably today considering this concept, that all of them might be present as individual entity, but they are interrelated and ultimately lead to a multiple of chronic conditions, which are known as the uh, defined as a caramel disease. So this is what the concept is. So that is why the concept holds. We do see that patient, in spite of being obese, having metabolically healthy fat, so they do not develop the caramel disease. So how do we manage? So management has to be very comprehensive. Multidisciplinary approach is essential. The key strategy is obviously to take control of the glycemia. And here the SGL2 inhibitors and GLP-1 receptor agonists plays an integral part in as a treatment protocol, because they can address both the glycemia and various other pathogenesis along with weight loss. Lipid management is very important. You have to use statins or other lipid lowering if the patient is statin intolerant. Blood pressure control also is important with both pharmacological and non-pharmacological measures. Weight reduction is utmost importance in if you want to have a good positive outcome in these kind of conditions. And regular screening uh, or anticipating that the other organs may be affected is also essential, so that you can come up or you can identify the health of the liver, the cardiovascular elements, the renal elements, the eye elements, and thereby you can take appropriate measures to take care of those organs. So to conclude, a collaborative approach to metabolic health is extremely important, and caramel disease is a conceptual framework that emphasizes the interconnected nature of chronic condition often associated with metabolic disorders. Understanding and addressing these interconnections is crucial for comprehensive patient care, ultimately improving outcome and quality of life. By adopting a multidisciplinary approach involving the healthcare professionals from various specialties, we can carefully manage effectively these conditions, promote healthy aging, improve the overall well being of the individuals with metabolic disorders. So, basically, the metabolic dysfunctions, which ultimately lead to caramel disease, will need a comprehensive, holistic management plan to address it. Thank you. And thank you for inviting me. I thank Professor Yusuf once again.